Dr. Parag Sancheti, Chairman of Sancheti Hospital, Pune, and it's a great privilege and an honor to welcome all of you for the Arthroscopy Insight, the first webinar. I think it will be imperative to say that arthroscopy is growing by leaps and bounds. And I won't be exaggerating if I would say that probably the love for arthroscopy in the last 4 to 5 years has grown over love for arthroplasty. And I'm seeing more and more younger surgeons wanting to do arthroscopy of the shoulder, of the knee, and of course the hip also, along with the ankle and elbow, which is still not a very popular entity. So I think this webinar is to promote arthroscopy as a super specialty, or if I may, subspecialty in orthopedics, and help colleagues, especially who have just started their practice, and of course the experienced ones with the cutting edge technology and more literature, so as to have a positive impact on the patients. So keeping in this in mind, we started thinking about it and launched this group called as Arthroscopy Insight Group, which will deliver webinars from time to time. Along with it, also we will be sending useful articles all across, giving links to great videos from surgeons, experienced surgeons, and then of course all this again with the hope that arthroscopy will become more popular. I just want to say one more thing, and I'll hand over to Mr. Dr. Shirish Pathak, who is going to convene today's webinar. And I am very happy that the topic chosen is on shoulder instability. I think shoulder instability is something which we have seen constantly, and we've moved away a lot from my residency days, where we used to just reduce the shoulder and forget about it. At the most, do a kind of a putty plats procedure. Those are the days which I started with, and now it has advanced so much in the last 33 years that I passed out my MS. So today's topic is really wonderful, and I want to thank Shirish. I also want to welcome our faculty for today, Dr. Vivek Pandey. Nobody doesn't know him. He's very famous with his great book he has written on clinical evaluation, and I'm happy and proud to say that all our residents are using that book on a daily basis. So thank you, Dr. Vivek, for
Thank you,
joining
sir.
us, and your great experience in arthroscopy of the shoulder will definitely be useful in today's webinar. We also have today Dr. Nilesh Kamat, who is a very experienced shoulder arthroscopy surgeon, along with a general arthroscopy surgeon, because he does a lot of knees, and he's trying to venture into ankle, hip, and elbow very soon. So welcome, Dr. Nilesh, and of course, our own Shirish Pathak, who's an alumni of Sancheti Hospital, and I have known him as a multifaceted personality. I think one of his facets is arthroscopy, so that gave him credit to be convener for this session. So welcome, Shirish, and I'll hand over the further proceedings to you. And I would request all those watching, please stay in tuned for more kind of such webinars, which we will be holding from time to time. And I want to thank all of you for joining. In the end of this webinar, we are going to showcase a video where there is a big shoulder meeting happening right tomorrow in Calicut. And we would like all of you who can attend in the area who have not yet registered to please attend that meeting, which will be held in Calicut tomorrow on shoulder arthroplasty, shoulder arthroscopy. So it will be a very useful meeting for all those interested in arthroplasty and arthroscopy of the shoulder, because that's again becoming a new subset where people do shoulder scopy and plasty. So with this preamble, thank you, Dr. Vivek. Thank you, Dr. Nilesh. Over to Dr. Shirish for further
Yeah,
proceedings. Thank you.
thank you. Thank you, Parag sir. First of all, I take this opportunity to thank Parag sir because he chose shoulder as an inaugural session or his sharpening arthroscopy skills session for this year. I welcome Vivek and Nilesh. Both are my good friends. And we will start with the program. So we have kept a very focused topic, shoulder instability. So Vivek is going to speak about how to approach clinically and radiologically a patient of shoulder instability. Then Nilesh is going to speak about soft tissue repairs in shoulder instability. And I'm going to talk about what is role of bony augmentation and when do you do that. So without wasting a minute, may I request Dr. Vivek to take over and share his screen and start with his talk. Thank you.
Thank you, Shirish. So let me share the screen. Is it visible, Shirish?
Yeah,
Yeah,
visible.
we can see. Yeah.
Perfect. Okay, Shirish, thank you so much. And thank you, Parag, sir, for inviting me for this inaugural session of the Arthroscopy Insights. Um, my talk is basically how do we make the decision making in the recurrent anterior shoulder instability. And right in the beginning, I'll say that I'll be primarily focusing on the traumatic recurrent anterior shoulder instability. Because of the lack of time, we'll not go into the details of the primaries or the atraumatic shoulder instability. So this will be mostly focused on the recurrent shoulder and anterior stability, though I'll be briefly touching upon others. We all know that if we have to treat the pathology of anything, we need to understand what is the basic anatomy, what is the role of all the structures, and how do they influence, how this pathoanatomy influences our decision making. And that's why the approach cannot be over unless and until we understand the fundamentals of anatomy and pathoanatomy. Then I'll go briefly into the clinical parameters which we take in account, the radiological factors, and then a very brief, generally acceptable treatment algorithm, because world over there is no, except you say the bone loss is more than 25%, there is, there's a lot of variation which happens between, let's say, 10% to 25%. So my algorithm may not fit everybody's book, but it generally answers and addresses a lot of our clinical patients. So we know that this is the classic Stanmore's triangle. This, in the most of the time, we get the polar type 1 type of instability, that is the traumatic and structural. But not uncommonly, we also see a bit of polar type 2, where the patient may say that they never give a classic traumatic history, but over the years they have been playing a lot of overhead sports, they have been doing swimming, and then they start dislocating. When you do their imaging, you do find that there's a Bankart lesion, there's a Hill-Sachs lesion, and maybe occasionally there are Bony Bankart, but they do not give any frank history of trauma. So over the years, their capsules and the has become more and more accommodative. The joints can dislocate with a little bit of ease. So shoulder stability, we all know, is the play between the static factors and the dynamic factors. The static are soft tissues and bony. The one which are highlighted in a little bit bold, that is labrum, ligaments, capsule, and glenoid anatomy. And the dynamic factors is the one which I'll just deal little bit, to let you know that how this anatomy helps us in making the decision. So we all know that the labrum is the one which circumscribes the entire glenoid. You can see here. Okay. And this is responsible for the chalk block. It's some kind of a restraint in the anteroposterior, the movement of the head. But more than that, it actually deepens the glenoid cavity. And along with the cuff, it helps in concavity compression. The second important structure which helps in stabilizing the shoulder, especially the anterior stability, is the glenohumeral ligaments. There are three of them: superior, middle, and inferior. The role of the inferior remains the most important because this is the one which primarily stabilizes the shoulder in the 90-degree abduction. We all know that most of the shoulders, they dislocate in Aber position, where the shoulder is in 90-degree abduction and about 80 to 90-degree external rotation. So the role of AIGHL, that is the anterior band of inferior glenohumeral ligament, is extremely important. And along with the labrum, whenever we do the repair of the labral tear and the glenohumeral ligament, it is the retensioning of the AIGHL is extremely important. And that is why we must understand that not merely the labral repair, the retensioning of this ligament is important. In a younger patient who is like in 20s and 30s and 40s, the cuff is normally intact. So the concavity compression, the compressive effect of the rotator cuff is always maintained. So it is not of a big problem. It does prevent excess anterior translation, especially you have the intact subscap in front, let's say. So that will prevent excess translation. It does help in proprioception in neurovascular control. Having said that, in this role of the cuff, becomes very important in the patient who are more than 40 to 45. And that is why there's this unsaid rule that when you have a patient who is more than 40 to 45, who have come to you with a primary anterior shoulder dislocation or even the recurrent dislocation, it is extremely important that you do rule out the rotator cuff tears. You will very rarely find the rotator cuff tears in younger patients, let's say 20, 25, 30. Their cuffs are almost always normal. But the patients who are more than 40, 45, the cuff is often torn. And they need the cuff repair plus minus labral repair. So the cuff function becomes more important in a bit more older patient because they're often torn. So in summary, if you look at this soft tissue pathoanatomy, labrum tears could be of variety types, Alpsa, Bankart, Perthes, or Glad. The glenohumeral ligament and capsular tear could result in loss of tension in glenohumeral ligament. It could be a haggle. Haggle means the avulsion of the capsule from the humerus side. Reverse haggle, the one picture shown is actually the reverse haggle, or it could be the gaggle where there is a glenohumeral avulsion from the labral margin, or it could be cuff tear. So these are the different soft tissue pathoanatomy. Now, this is usually these two labral tears plus minus, this haggle, reverse haggle, and gaggle are a bit uncommon, but this is almost always happens along with any of these. Cuff tears are usually seen in more than 40 to 45. And that is why if you have a patient who is having primary or recurrent traumatic anterior instability, it is extremely important that you do their MRIs, because MRI will pick up a labral tear or a capsular injury or a glenohumeral ligament injury, but you are going to miss a cuff tear if you're not doing MRI in the older patient. So this is what I told in the beginning. The labral lesion alone is not responsible for the instability. The essential lesion is actually the loss of IGHL. And this is primarily the, Nilesh will talk about when we repair the labrum, it is very important that you restore that tension. Mere reattaching the labrum just back to the glenoid shall not lead to a good result. You have to restore the tension by good chalk block effect. Coming to the bony stability, the bony stability is imparted primarily by the glenoid, the anteroposterior width, because, glenoid is a very shallow bone. It is just like this structure where it is very, very prone for the instability. So pear-shaped glenoid fossa that covers almost just 25 to 30% of the humeral head. It gives the stability by the passive bony congruence and a bit of the upward tilt and retroversion. They resist the inferior and the anterior translation. Now, in the pathoanatomy, as the dislocation happens, we all know that the head of humerus, when it is here, it will keep translating inferiorly, recurrently, eroding this margin. Either it will gradually erode, or it can first time itself break the anterior piece of the glenoid, which we call it as a bony Bankart, which may eventually get resolved. So this glenoid stability today, currently, if you ask me what is the most important critical factor which helps in decision making, of course, because everybody has got a labral tear, almost everybody. It is the anteroposterior dimension of the glenoid which helps you in the decision making. So the critical bone loss to start with, after the red flagging of the Jody Beer, it was the seminal work of the E.G. Toy, who said more than 25% of the glenoid bone loss, then the soft tissue repairs will fail. So historically, about 20 to 25% bone loss, people were doing the bone block procedure, which Shirish will talk about. But over the years, they realized that even people who had, let's say, 17%, 16%, or 15%, and lastly, 13.5% bone loss, the patients were still having a higher chance of recurrence. So currently, it is still being debated. Is the critical bone loss 20 to 25%, or we can say now it is narrowed down to 13 to 15%. There is no, one take on this. It is yet to be debated. And that is why in this between, let's say, 10 to 20%, you have to, consider the age of the patient, occupation of the patient. Is he an overhead athlete? Is he a contact athlete? And modulate your treatment plan. And that is why I said in the beginning, there is no perfect algorithm at the moment, especially for this gray zone of 10 to 25% of bone loss. There you have to take these various factors in account before you operate your patient. In the humeral head, this is very classic, the Hill sacks could be engaging on and off track. Engaging has been almost debated, and everybody agrees that almost every Hill sacks lesion has sometime engaged. So engaging versus non-engaging per se is not very relevant. What we currently use is on and off track, which I will show in one of the slides. So we all know the off track and on track. If the size of the Hill sacks lesion, so this is the glenoid track. So glenoid track is basically, let's say this is glenoid and this is the diameter of the glenoid. So it is almost 83% of the diameter. So if the diameter is, let's say 24 mm, 83% will be roughly about 20 mm. Okay, so 20 mm is the track of the glenoid. So if the width of the Hill sacks is less than 20 mm, then it becomes a on track. But if the glenoid track is smaller, because glenoid track depends upon the current dimension of the glenoid. So if there has been a bony erosion of the glenoid, then the track is further smaller. Very same Hill sacks lesion, which can be on track for a normal glenoid, will become off track. Off track means the width of the Hill sacks lesion is wider than the glenoid track. And why this is important? Because in on-track lesion, you can leave it theoretically. It may not engage after the Bankart repair. Whereas an off-track lesion has got a very high tendency of engaging back even to the repaired area, which may lead to failure of the repair. And that's why in the off-track lesion, the current philosophy is one can take up the remplissage, that is the tenodecing the infraspinatus tendon into the defect. The only so-called downside is subtle loss of external rotation in the Aber position, which might not be a very desirable thing in an elite overt athlete like something like Neeraj Chopra, who really need to externally rotate their arm or shoulder in the Aber position. So this is the gist of pathoanatomy. Soft tissues, generally we need to know the role of labrum, glenohumeral ligament and capsule. Most of the time it is the labrum which is torn. Sometimes the glenohumeral ligament can be torn from the humerus side anteriorly or posteriorly. Sometimes there are in situ capsular tears also. Among the bony, the most critical finding is always the glenoid AP diameter and the Hill sacks width, which will give us a concept of the glenoid track. So with this, we move on to what we need to take in the history. So the first and foremost important thing in the history is the age of the patient. How old is the patient? Because younger the patient, what kind of occupation he has got. So let's say occupation and sports. If he's young, if he's an overweight athlete, an elite athlete, or he's in an occupation where every now and then he has to overhead abduct his shoulder with the load, even a 15 to 18% bone loss can become significant. And they might have to be managed with the bone block. Whereas let's say you have a patient who is 45-year-old, 40-year-old, who is a sedentary worker, doesn't play any sports. He's not commonly involved in an occupation which requires a very repeated overhead abduction or Aber position. A same 18% bone loss can be managed with a soft tissue Bankart with or without Remplissage. And that is why I am again emphasizing there is no perfect cutoff of the glenoid bone loss in the shoulder instability management. Yes, after 2025, there is a very less debate, but this all debate is happening between 10 to 20%. Now, you always ask in OPD, how did it happen? Is it traumatic or over the years of micro trauma or atraumatic? So atraumatic, that is Embry, it's another beast. This is for some other day. But traumatic and years of micro trauma do indicate that there is a capsular or labral plus minus capsular injury along with the bony defects. Is it a dislocation or is it a subluxation? Okay, so repeated dislocation usually indicates a bit more of, they may, indicate more of a bone loss, more of soft tissue injury than the subluxations. Is it reduced by self or doctor? If every time it is reduced by self, it means that the soft tissue and the probably the bony, combined defects are so large enough that it becomes very easy to go in and go out and anybody can reduce it. Along with that, it also indicates that the shoulder might be lax. If every time a doctor's needed, it could also indicate that the Hill-Sachs index, Hill-Sachs could be very deep, and that is leading to a locked, kind of a locked situation. How long it has been immobilized in the beginning. Night dislocation, we recently have just published a study, it is yet to come, that night dislocation, whenever it starts dislocating at night, it again indicates a large bony lesion or a major soft tissue deficiency. Most of the time, it directly correlates with a very big bony lesion. Let's say somebody had a dislocation at 20, then second dislocation at 25, then third, fourth, fifth has happened in the last 6 months when he's 30. It means that the soft tissue or bony deficiencies are increasing. A off late increasing frequency again indicates that the lesion might be increasing now. A recurrent dislocator usually is not very painful in between the two episodes, but if the pain is increasing now, if there's a locking, that it may increase, it may indicate that probably the lesions are expanding from anterior, it might be going to posterior. There may be a labral flap or like something like a labral bucket handle tear, which is also causing a locking, or there's a loose body. Comorbidities are extremely important in management, especially epilepsy. You cannot operate a patient unless the epilepsy is under control. Whether there is any family history of collagen disorder, that needs to be kept in mind. And any previous treatment patient has taken, especially in terms of surgery. So these are these are the parameters which we take in history, and then it gives you some kind of a clinical relevance. You can always go back to this recording and see how these things are important, because I have already explained each one of these categories. When it comes to examination, I personally start with patient generally in standing. I check the Beighton score. I check the range of motion in all the planes. Of course, the combined Aber movement is a little difficult to do because sometimes they may be very apprehensive. First, assess always the neurovascular examination, check the scapular dyskinesia, and then go ahead with the test for the labrum and cuff. I'll not go into the details of test because that's not the primary objective. You all know about these tests. Anterior instability or anterior stability, my favorite test because it has got a very high sensitivity and specificity, is relocation release. People do try apprehension, but the only problem with the apprehension is that it can lead to a spot dislocation. So I have stopped doing any apprehension test. Anterior drawer can also be done. But then again, most of the time, the information what you need is the relocation release test. Posterior instability or stability can be checked by the jerk test. Jerk test may give you only pain. The classic jerk, the reduction by jerk, is not very frequent. Inferior laxity must be checked in all the patients. So if sulcus sign is positive, it indicates that the shoulder is quite lax. And in such cases, you might need to do the rotator interval closure. That is why this particular test is important. You see, the classic teaching is every test what you do, you must know that why am I doing this? Is it giving me extra information? You repeat, you do the next test only if it gives you extra information. If all the tests are giving same information, then stick to one test. This is very important, very, very important. Slab. I'm sorry for the spelling. This is O-brand, not on-brand. So O-brands and the crank test and the compression rotation test, there are a couple of tests. Remember to do at least 2. I personally do the O-brand both in standing and in lying. And I'll tell you the logic. In standing, if the scapula is slightly unstable or a bit dyskinetic, patient will have pain and decrease in the strength. When you make the patient lie down, the very same slap which was kind of little weak or slightly painful becomes very strong. Then it means that what slap which has been reported by the radiologist may not be very relevant. Then you have to rely upon the probing during the arthroscopy. Because remember, type 2 slap are often over-reported. That may not be really the situation. So that's why you try to repeat this test both in standing and supine. Last but not the least, especially in the older patient, 30, 40, 45 and above, always and always check the cuff strength. So with this clinical findings in mind, we go to the radiology. There are the three classic tests: X-ray, MRI, and CT. And right in the beginning, I'll tell you, largely for all practical purpose, contrasts are almost out as of today, because the 3D MRI gives beautiful picture, especially if it is an acute dislocation, because the hematoma itself can act like a contrast. There are a variety of X-rays which have been described in literature, and people keep describing. We have papers and papers on this. But one thing is very clear, that none of these radiographs, none, they help in any of the decision making. Nothing. You cannot make any decision. Should I do the soft tissue repair? Should I do the bony repair? Should I add Remplissage? How deep is it? Because it keeps varying. So it's simple. If an investigation does not help you in decision making, then don't do too many. You just do the AP view. You can do one axillary view, and that's it. Then why should we do at all? Because it helps in a baseline imaging. You can rule out any fracture. Sometimes there are GT cyst or a glenoid cyst, which can be seen. It tells you the degree of osteoporosis, especially if you're operating more than 50, 55-year-old male or a female. Is there any evidence of pre-existing arthritis? Because for arthritis, there is no other better investigation than the X-ray. It will tell you straight away, the Samuelson Preto 1, 2, or 4, whatever. And is there any other pre-existing lesion which you're going to miss it? So always do one baseline X-ray. But in today, 2025, no one makes a decision of soft tissue versus bony with the help of X-ray. So there's no point doing any of these fancy X-rays. This remains for most 99% of the serious shoulder surgeons. This is the classic investigation to be done. CT scan with a 3D reconstruction, where you can see the on-face view. Just mere 2D will also not give you the real finding. You have to do the 3D. So here on the left side, you can see this is a classic bony Bankart. This is the normal pear-shaped glenoid, whereas this is the complete straight line or slightly concave, indicating that it's almost a 25 to 20 to 25% bone loss. On the humerus side, it helps you in assessing the on or off track lesion. So a recurrent dislocator, if you ask me, traumatic Tubbs type recurrent dislocator, or even Stanmore type 2, my starting is always with CT. If somebody can give me, like the Pune team, a complementary MRI, fantastic. But I always want a CT scan to know the bone loss, because primarily at the moment in 2025, your cutoffs of soft tissue versus bony is based on bone. And bone assessments are not yet perfected on MRIs. Maybe in another 5-10 years, we'll have excellent MRIs where we can see the glenoid bone loss. But at the moment, it's not very clear. MRIs do help you in soft tissue test assessment, type of labral tear, whether it is Alpsa, Bankart, or Perthes. But trust me, you ask any shoulder, does it make a difference in management? None so far. So it doesn't make a difference. It's a nice, fancy postgraduate, the exam question, but it has zero relevance. How do you manage them? Haggle, reverse Haggle, yes, you need to be prepared for them. Gaggle can be a little bit of a trouble if you don't know about it. Slap, for slap, yes, it is not only radiological diagnosis, but you must always know the clinical. What was my clinical finding? Pasta and cuff, especially if the patients are slightly they are becoming more and more older, they may have a cuff pathology. These scorings, that is ISIAS and the glenoid tract instability management scores, they are nice. They can help you in some amount of prognostication, because especially if the scores are going more than 4 to 6, there's a chance of recurrence. So finally, when we have the idea of the anatomy, pathoanatomy, have a clinical factors in our hand, and we know the radiology, then we make the decision. And how do we make the decision? So not only you see the pathoanatomy, which comes from these three factors, it also comes from age, occupation, and sports. And is there any other comorbidities? So if I cancel this also, still what patient is doing, what he wants to do in future takes a precedence in the entire conservative versus operative. Nilesh, I have 5 more minutes. I'm done almost.
Yeah, sure. No worries. No worries.
Done. So conservatively, largely it is left for the primary shoulder dislocators, especially if they are more than 25 to 30. But again, in 2025, they say it's a combined decision. It's a decision which is made between the surgeon and the patient, because some primary dislocators even we operate now, but most we give a chance for it to heal. If he is an in-season professional athlete who is doing very well on rehab, you can leave them for the time being and operate them after the season. And if it is MDI, that is multidirectional instability with Stanmore type 3 of pattern. For all practical purpose, this talk is basically about the recurrent dislocation. So failed conservative treatment with recurrent dislocation, young patients who need to return to work who are prone for recurrent dislocation, let's say, especially those who are involved in the overhead sports. Even those who are not involved in overhead sports, it has been found that less than 20, if patient is less than 20, there is a possibility that he will dislocate. What is the probability? We don't know. Maybe it goes anywhere between 60 to 70%. Now you are within 60, 70 or 30, we don't know. So again, here you have to make a decision with the patient. And displaced bony Bankart lesion, I personally feel that it's important to fix now, because now you can fix it anatomically. You can get the patient's original bone. If you leave these lesions for 5 years, we all have seen that after 5 years, there'll be no bone. You will be end up having 15 to 20% bone loss. And if the patient is young, you have to do the bone block procedures or Letage. So operative decision depends upon the structural profile, that is glenoid bone loss, off and on track, labrum and capsule quality and laxity, and patient profile. And this is my simplest possible algorithm. I know it's not coming from any textbook. This is what I generally follow. There is something which I will also say I have not written here. So if the glenoid bone loss is, you see, it is almost divided in straight away two parts, less than 20, more than 20. And then last, this column is a column of debate. So if it is more than 20%, or let's say you can stretch it max to 25%, there is no confusion. You always do, for all practical purpose, Bony procedure. We are not debating the nitty-gritty. 20 to 25% do the Bony. Now, along with the Bony, there is a group of school of thought which say I can add Remplissage. Fair enough. You're welcome. Do what you wish. But more than 20, anteriorly at least add a bone. Now, whether it is a free bone block or is it a Letage, classic Letage, that Shirish is going to discuss. Less than 20%, if the labrum capsule quality is excellent, thick labrum, nice capsule, you can, and the heel sacs is on track, you can go ahead and just do the arthroscopic Bankart repair. But people like me over the years have realized that now what is on track? So let us say glenoid heel sacs index is at the moment, let's say 15 mm. And your glenoid track is 16 mm. So there's a 1 mm difference, and then you say this is on track. But this is a static measurement. There can be error in the measurement also. So what is on track in static position can become actually off track in a dynamic. So a lot of people still add Remplissage, but that's an individual variation. If the glenoid bone loss is less than 20%, but the capsule labrum looks thin, stretched out, then current philosophy, which is emerging in the last 5 years, 4 to 5 years, is you can do Bankart plus, that is DAS, along with the on-track lesions. So you can do DAS or the anterior subscapularis tenodesis, but they are under the the observation. Maybe another 5 years we'll have a clarity of thought. Again, less than 20%, good or doubtful quality of the whichever way, but if there's a off-track heel sacs lesion, one can straight away add the Remplissage, which has given last 10 years very consistently good result and reduction in the dislocation. More than 20%, as I said, Bony procedure plus minus Remplissage, because there are some people who say you can add it. Now, the last one is debatable. More than 13 to 15% in a patient who is an overhead athlete, contact athlete, who really needs to go back to work. He lifts a lot of load, and there's a likelihood that the arm will suddenly go in external rotation. Bony procedure again is becoming the procedure of choice. So with this very simplest, briefest algorithm, without having too many evidences, which I'm known to put up, I think I'll stop my talk here. Thank you very much.
Thank you, Vivek. That was a wonderful lecture, very lucid, very informative. And I think audience will definitely get a great clarity how to approach clinically, what is basic minimum required in investigation, and rough algorithm. So I think now from here we'll take this discussion to the next level. Nilesh, can you start your talk about how would you do a right Bankart repair or soft tissue repair?
So great. So I'll share my screen. Thank you, Shirish, for the invitation. And let me know if I can see my screen clearly. Can you see my screen?
Yeah, we can.
Right. So, and can you see the first slide?
Yeah.
Excellent. So as usual, great Vivek, an absolute comprehensive overview. It allows the younger colleagues and other shoulder surgeons to understand which are the patients where you would want to consider what procedure and how do we go about this. What I would be discussing in the next 10 minutes is a technical video on how to do an ideal arthroscopic Bankart repair. This was aimed with the idea of helping younger surgeons try to overcome technical difficulties from right from positioning to how to take the bites and how to maintain the tension and to go ahead with a Bankart repair. So going on with the talk, I'm not going to talk much about the theory. We all have heard that the inferior glenohumeral ligament forms the hammock concept, and that is what is important. And when you talk about a hammock, what does it mean? It literally means that someone is cradling the humeral head. So if you look at this animation, you can see this is a hammock which you'll see at most of these resorts when you visit them. And the central portion of the hammock is suspended. And if you have to apply this concept in the shoulder, you can imagine you have the scapula at one head with the inferior aspect of the glenoid attaching one attachment of the hammock. The other attachment is at the level of the humeral head, and the head is now cradled. So think about it from an end-on view. And this is where the hammock is acting as a nice cradle for the humeral head to sit. When any of these attachments of the hammock gets disrupted, whether it's at the scapular end or whether it's at the humeral end, the shoulder is going to dislocate. So when you're going to do a repair, you want to restore this. And as I explained earlier, that the failure can happen at any end. So when conventionally it takes place at the capsulolabral complex or the anterior-inferior capsulolabral complex, it's called a Bankart tear. I wouldn't go into technical details of the other injuries because that's beyond the scope of 10 minutes, but this is a surgical trip and tricks for Bankart repair. So this is effectively an essential lesion where you're looking at the anterior-inferior part of the capsule along with the labrum being disrupted. When you go ahead and get an MRI for them, you will see these two typical lesions. On the posterolateral aspect of the humeral head, you will see an impression fracture, the so-called Hill-Sachs defect. And on the anterior-inferior aspect of the glenoid, you will see a labral separation. When you're considering these patients up for repair, you could either do them in a lateral decubitus position or beach chair position, depending on your training. You need your correct portal placement. In this particular scenario, you're looking at the posterior portal, the anterior superior portal, and the anterior inferior portal. We'll discuss about that in a bit. It's important to cause adequate spacing of the portals because you don't want crowding of portals. And yes, in the initial period of your surgical journey, definitely worthwhile to use cannulae to prevent suture entanglement and a messy procedure as time goes by. Once you are a master at things, it's up to you whether you would want to use a cannulae or not. So this is a typical setup in our operating room. I operate all my patients for anterior instability in a lateral decubitus position. I use a dual pulley system, which allows for a lateral abduction pulley as well. And why so is because you want distraction of the humeral head. Because once you do that, that is when you're going to prevent scuffing of the cartilage, and it's going to allow you to come right along the base of the anterior inferior glenoid. And we'll show about that in the video. So this is how, from a conventional posterior portal, you're going to look at the glenoid. Now, for orientation, understand that you're looking at it from behind. On the left of the screen is the foot end. On the right side of the screen is the head end. On the upper side is the lateral side. and medially you're looking at the glenoid. So now let's run the video again. You can see the first thing you see is the glenoid. As you're coming along the anterior inferior aspect, you can see that the AIGHL band, that's the anterior band of IGHL, is what is being seen right across. What you can't see is that there is no labrum which is attached along the anterior inferior aspect. Along the anterior superior aspect, you can see that. And posteriorly, you have the Hill-Sachs defect. At this point of time, you would want to go ahead and create an anterior inferior portal. Where is the anterior inferior portal? If you look at the coracoid, just lateral to the coracoid is where you're going to place your spinal needle for the anterior inferior portal. Arthroscopically, this is going to be just above the subscapularis, and it's important that the spinal needle reaches right up to the point of 530, because if your spinal needle can reach, that is when your drill bit and your anchor can reach. You can then use a switching stick to dilate this. You can either use a 7 mm clear cannula or an 8.25 mm cannula, which is a clear cannula, so it allows the passage of sutures well. And then you can do a classic diagnostic scope. And here you can see that there is no labrum. I can't see the labrum, and there is no support for the humeral head as a restraint. Once you're done with this, this is where you would want to consider doing the anterior superior portal. Now, where is the anterior superior portal? It's right off the edge of the anterior margin of the acromion. So in the rotator interval, anterior to the long head of biceps, you're going to place your needle, and then you're going to get your switching stick to pass through. Although these two portals might converge in the rotator interval, understand on the skin they need to be divergent. And that's important, because once you have a divergent portal on the skin, it allows you to have adequate working space. So that's where your switching stick comes in, and you have your anterior superior portal. Now you're going to swap over and view from the anterior superior portal. So you're looking at it from the top of the hill, and posteriorly, now you're going to insert a clear 5 mm cannula. So now you can imagine you're sitting at the top of the hill. On the left of the screen, you have your 5 mm clear cannula, which allows you to probe right from the bare spot, whether there is bone loss, as to how the cartilage is looking at, and you're getting a complete end-on view of the glenoid. The anterior inferior portal is going to be on the right side of the screen, from where you're going to probe the labrum, and there you can see the labrum sitting right on the medial aspect of the neck of the glenoid with the anterior band of the inferior glenohumeral ligament. And this is the view that I would want, because without this view, it's impossible for me to know how much am I going to repair. The next step comes on is to elevate this labrum off the medial edge of the neck of the glenoid. So with this animation and picture, you can see you can use a 15-degree elevator. I prefer to use a traumatic elevator so that I can take the adhered tissue of the labrum. Many times you're worried that is it going to cause too much bleeding? It is expected to cause bleeding, but that clears out in a bit. And you would want to go ahead and clear right all the way across, right to the apex of your glenoid along the inferior aspect. Why so? Because you're going to create a shift, and there is no harm in sometimes extending the tear to go beyond the 6 o'clock using a curved up biter. Be very careful that you're not doing a blind bite and you're sticking close to the bone. A common question asked is how much elevation is required. There are two parameters that you need to look for. One is that you should be able to see the fibers of subscapularis as what is being seen here. And second, the labrum should float at the level of the gleam. Once that is done, that is when you're going to use a rasp. Understand, in arthroscopy, you're using anchors to repair the tissue, but that's not going to bring about healing of the tissue. You need to create a conductive atmosphere, the biology for healing to take place. And that's where you're going to use a rasp. Either a mechanical rasp is an option, alternatively, you can use a shaver to clear off the medial aspect of the neck of the glenoid, which creates a bleeding surface. Once you're done that, then comes the important step of anchor placement. Earlier, the thought process was, do we put in the anchor on the edge of the glenoid? When you do that, understand you're getting the entire capsulolabral complex back to the neck of the glenoid, not on the face of the glenoid. And that creates an iatrogenic alpha lesion, so it might probably not be so helpful. You've heard Dr. Vivek Pandey talk about the choco-block effect. You want something to have a bumper effect right on the top, and that's the reason it's worthwhile to go in and put the anchor right on the face pretty much at 5:30. Now, you need to be careful when you're doing this with the soft tissue anchors, because in the soft tissue anchors, you're going to go a further depth. And if you're going to go right at 6 o'clock, there is a chance you might penetrate the cortex and you can cause an iatrogenic injury to the axillary nerve. With the curved sleeves now available, it allows you to drill the anchor within the bone of the glenoid, and you don't need to penetrate the far cortex. Once you're done that, you're going to activate the anchor and see that both your limbs are sliding comfortably so that you don't have any issues in knot time. After you're done with this, you need to separate the suture limbs, and the limb closer to the labrum is then taken out via the posterior portal. So here you can see that you're going to harvest one limb from the posterior portal. And after you're done with this, you're then going to use an indirect type of suture passing device, which allows you to take a bite of the labrum. It's extremely important from where do you take this bite. If you take the bite at the level of the anchor, you're just causing an east to west shift. But understand, you want to also cause a south to north shift. So when you're going to go and take a bite of this portal, always see to it that you're further inferior and distal to the placement of the anchor, and the beak of your shuttling device should come at the level of the anchor. So that creates an antero-inferior shift. And once you've done that, either you can use a nitinol loop or a monofilament suture and then shuttle the suture across. And here clearly you can see that the shift is not just medial to lateral, it's antero-inferior to posterior-superior. And that's what you would want to do. Once you're done this, after you relate the suture, then sequentially you're going to look for sliding of the sutures and you're going to do the knot time. Again, a common question asked by junior colleagues is that which is the post and which is the throw? The suture which passes through the labrum is the post, and the suture which comes from the anchor is your throw. So once you do that, that's when you're going to do a sliding half hitch knot or a locking kind of knot. It's important when you do this, you tension it across rather than just pull it across. When you tension it across, that allows the shift of the anchor. There is another trick that you can do, the so-called noose maneuver. That means when you're tying the knot, you hold the labrum and you manually shift the labrum up from the posterior portal and then tie it across. So this does not just bring about the shift caused by the sutures, but the manual shift which is brought about by the grasper or the suture retriever from behind further allows the shift of your labrum. In a sequential manner, you're going to go ahead and do minimum of 3 anchors. You can do as much as 4 to 5 anchors also, with the end result of creating a robust repair like what is being seen out here. Understand, in a relook arthroscopy, you might not necessarily see the bumper, but it is the tensioning which is important. And here you can see visualization from the posterior portal clearly gives a bumper effect and clearly gets retensioning of the entire antero-inferior labral complex. What in a scenario where you have not just a labral tear, but also a defect at the back of the humeral head? But you have heard Dr. Vivek Pandey talk about the concept of on track and off track. Not getting into technical details because we are talking primarily about a Bankart repair, but without hesitation, when you're looking at an on-track lesion, there is no harm in, when you're looking at an off-track lesion, there is no harm in going ahead and doing a remplissage. Now, what is remplissage? Remplissage simply means to fill. It comes from the French word to fill, meaning you're filling the defect with something. So what is that something which you're going to fill the defect? Posteriorly, you have the infraspinatus with the posterior capsule, and that is what you're going to fill in that defect. So here you can see a case where there is a sizable defect on the posterior aspect of the humeral head. You can go ahead and you can put in an anchor in the center of the defect. It depends on the surgeon whether you want to do a single anchor, whether you want to do a double anchor. In a sequential form, you're going to pass sutures from the posterior capsule and the posterior infraspinatus. I like to do them in a dual row format. So you can see the white set of sutures are more towards the glenoid. The blue set of sutures are more away from the glenoid. So that creates a broader surface area for the entire infraspinatus and the posterior capsule to come in and to fill the defect. Clinical implications, you have heard in the previous talk that in a position of abduction and external rotation, there is slight slight loss of external rotation, and there have been some great publications by Dr. Pandey himself, and you can probably look up that to understand the clinical implications. But in an overhead athlete, you need to counsel this to the patient earlier that you might lose out on movement. But if I'm looking at someone who's a low demand person who's okay to lose out on that abduction, external rotation, full range of movement, I wouldn't hesitate in adding a remplissage to reinforce my Bankart repair so that there is no failure. Does the post-op protocol vary? In both the cases, I would be using 3 to 4 weeks of sling immobilization. In the initial phase, there is a needs phase 1 exercises where you are allowed to move the elbow, you're allowed to move the fingers, close chain pendulum exercises. Passive range of motion is gradually started. You progress to TheraBand after 4 to 6 weeks, return to sporting activities after 6 months of time. So if I have to give you a take-home message, understand your pre-operative evaluation and approach is important. And if you have to address something, address the primary pathology. In this particular scenario, it's the anterior-inferior labral tear. From a Bankart repair perspective, your inferior anchor placement and your inferior anchor bite is probably the most important constraint. A Bankart repair involves not just a east to west, but also a south to north shift. So it's a biplanar shift right from below to upwards and from anterior to posterior. And your knot time should be perfect so that you don't have a failure and loosening of your repair. Thank you.
Thank you, Nilesh. That was excellent talk, and I think you have covered each and every step of arthroscopic Bankart and how to get it right. So I
Thank you.
think now moving towards my talk, which is last part of this session. Let me share the screen. Okay. See my screen?
Yes, sir.
Yes.
Yeah. So I'm going to cover. Just give me a minute. Just reduce this. Yeah. Okay. Yeah. So I'm going to cover the role of bone augmentation in shoulder instability. Now, after listening to Vivek and Nilesh, now we have come to a conclusion that glenoid bone loss and of course humeral bone loss is very critical in decision making. We all agree that 20 to 25% of glenoid bone loss is the critical limit where we decide, yes, I need to do bone augmentation. We are also aware of importance of subcritical bone loss, specifically in a high risk patient group like contact athletes or military recruits. And we are also aware about humeral bone loss, on track and off track Hill-Sachs lesion. Now, when you are dealing with instability with bone loss, by and large, we have three options available to us. One is Bankart with Remplissage. Second is Arthroscopic Bankart Plus with glenoid free bone grafting. And then we have the third treatment option, which is lethargy. Either you do open or arthroscopic. So again, in sync with what Vivek said, so if you go through this flow chart, which I follow, if you have more than 20% of glenoid bone loss, you definitely need a bone augmentation procedure. If you are in a subcritical zone, about 10 to 20, then probably in high risk age group, high risk patient group, you will do arthroscopic free bone glenoid reconstruction with standard Bankart repair. So why glenoid bone loss is important? I think it has been emphasized adequately. If you do a very good Bankart repair in unindicated patient, like someone who has got more than 20% glenoid bone loss, in spite of following every step of Bankart repair, you are bound to fail, because if there is glenoid bone loss, only soft tissue repair in high demanding athlete or a person is not going to give you a good result. Rather, the recurrence rate is 16 times more, as published by Jody Bear and Burkhardt. So it is very important to suspect glenoid bone loss the moment patient walks into your OPD. So someone who says, I have more than 20, 30 dislocations, I have night dislocations, while examination you find he has got mid-range instability. When you look at X-rays and radiological investigation, and if you find there is loss of double cortical sign on just through AP X-ray, if you see a bony Bankart, or if you see blunting of anterior rim on axillary view, that would create a doubt in your mind, am I dealing with a bone loss, especially on the glenoid side? And it is very important to understand there are different types of bone losses. So one is acute scenario, acute bony Bankart. Then there is a partial attritional bone loss, and then complete attritional bone loss. So we should be able to classify the bone loss of particular patient into these three groups. So just to re-emphasize, a 3D CT on-face view of glenoid surface with digitally subtracted humeral head is the most important view I want to see when I'm going to make a decision whether I'm going to do a bone augmentation. So this is a very good method described by Sugaya, a best fit circle. So you put a circle, best fit circle, touching the posterior and inferior part of the margin of glenoid, and then you measure the diameter of this best fit circle and measure the dimension of the lost bone, which is exactly from the periphery of the circle and the anterior margin of the glenoid. And then you do calculation to find out how much is the bone loss antero-inferiorly. If it is more than 12 up to 20, it is subcritical. If it is more than 20, it is critical. In case you have not done preoperative investigation and you have ventured into arthroscopic evaluation, and if you find something like this, what is called inverted pair, then don't go just with soft tissue procedure. You have to add a bone augment over there, because this is inadequate bone of glenoid. And if at all, if you do only soft tissue repair, then this is bound to fail. So by and large, when you're having acute bony Bankart displaced, probably you would do arthroscopic bony Bankart repair. If you are having a partial attritional bone loss, you may do lethargate or free bone graft. And if you have more than 30% of glenoid bone loss, what I typically called a banana glenoid, then probably you need iliac crest. So what are indication of bone augmentation? Typically, bone loss more than 20% or combined bone loss, which is a off-track Hill-Sachs with a glenoid bone loss. If you are doing a arthroscopic repair and if you come across a very poor soft tissue quality of labrum, then it becomes an extended indication to put a bone block over there. Or if you have a failed arthroscopic repair and there is no soft tissue left for repair, then you can consider Bankart, lethargate or a Bony procedure as an alternative option. And in contact athletes or irreparable Hagel lesion, one can think of Bony augmentation again as an extended indication of Bony procedure. So lethargate procedure, by and large, it is the gold standard as of today when you deal glenoid bone loss, which is critical. So it has got a triple blocking effect. The first is a glenoplasty effect, where you are adding the bone where it is already lost. You are doing a capsular repair. You are repairing IGHL back to the glenoid or to the coracoid graft through CA ligament or anchor, and the dynamic ligament effect of conjoint tendon and firing subscap. So these three effects eventually restore the dynamic stability of the glenohumeral joint. There are two techniques to do lethargate. The classic one is Gilwal's technique, and the another one made popularized, made famous by Jody Bear is the congruent arc technique. Just to brief the differences, Gilwal's technique is you osteotomize the coracoid and the inferior part of the coracoid goes and gets seated onto the neck of the glenoid. While in congruent arc, you take the advantage of the concavity of inferior surface of coracoid. You turn the coracoid graft by 90 degree and you match the concavity with the concave surface of the glenoid. So they are ideally matched for the morphology by nature, so you can take advantage of that. But of course, there is some advantage, disadvantage of each technique. If you do Gilwal's technique, then probably you don't get the concavity. But if you do a congruent arc technique, then you do get the concavity, but then the thickness of your width of your coracoid graft is thinner when you turn it in 90 degree. So in a typical Indian short stature patient, you may find it difficult to put a 4 mm screw. So you can choose the whichever technique you want and go ahead. So just to show you what is lethargic surgery, you are osteotomizing coracoid, splitting the subscap, and fixing this bone block with 2 screws in the anterior-inferior part of glenoid. So this, together with triple block effect, is going to stabilize your joint. So I won't go through the detail of this video, but this is the coracoid osteotomized graft. You're making 2 holes, and typically I put 4 mm cannulated cancellous screws. You do the measurements and exactly match this.
Shirish, you are likely muted. Can't hear you.
Shirish, can you hear us? I think he's not aware about the fact.
I know here it shows that he's not muted, but there's some problem.
Message? Can we pass a message?
Shirish, uh, Shirish, your audio is not coming. We are not able to hear you. Shirish? Hello? Hello? Nilesh, can you hear me?
Yeah, we can hear you, sir.
Yes, I can hear you. I can hear you.
And Shirish is we are able to hear Shirish, no?
No, yeah, we can't hear Shirish because he is actually on unmute, but unfortunately, I'm trying to. One second, one second. Hello,
Let us Shirish?
Shirish, you're not audible. You're not audible. Yeah, yeah. So I got through him. He's trying to fix his
Just speak a
connection.
little loudly, Shirish.
No, he's trying to fix his connection. He got the message that he is not audible.
Okay, okay.
Hello.
Yes, Shirish, we can hear you now.
Yeah, yeah. So I don't know how
Okay.
much
Shirish,
I think you can just
Shirish,
go
you
back
can
5
you can
slides.
go back. Yeah, you can go back to Arthroscopy.
Okay, okay. Just a minute. Okay. Can you hear me now?
Perfect.
Yeah, now this is fine. Yeah, now this
Yeah.
is fine.
So,
Yeah.
so what I was talking about is, yes, the same open letharget can be very well done arthroscopically, but the downside is it is technically demanding. It's a long learning curve to learn arthroscopic letharget. It is time consuming, and you have to dissect nerves like axillary nerve, musculocutaneous, and the complications are unforgiving. And for someone who is tuned to do a lateral position surgeries, it is challenging to adapt to beach chair. But yes, if you give time and learn the proper technique, you can do this and give equally good result with arthroscopic technique. So now, are we looking at any other procedure which is more ideal, which is arthroscopic, which does not involve subscap split, which is more anatomic and without metal screws and reproducible in average surgeon skilled hands? Then probably this is the technique where we do Bristow's technique using a button fixation, and this is popularized by no other than Pascal Bulow. So I'm going to take you through one case where I had this patient, 28-year-old student with recurrent dislocation. He had history of sleep dislocation, and you can see on the end face view of glenoid, he had 18 bones. So what I did was uh, spine graft, and this is the arthroscopic image. You can see this is the right. You can see a Bankart tear which is extending almost up to 6 o'clock, and this is a classical Bankart, and you can see there is a blunting of anterior part glenoid. Those steps like any standard Bankart repair, what just now, but only thing is the extent of this dissection goes little extended up to 7 o'clock and superior almost up to, because you have to create a space to accommodate the free bone graft.
Shirish, we lost your audio again.
Nilesh, I think you can call him. Nilesh, just call him once.
Yes, I'll do that. I'll do that. You lost your audio again. Hello? And तुझा audio परत गेला.
Okay.
And now this is better. Now we can hear you.
Yeah. So I think last. So
So The point where you were creating the tunnels after the amount of dissection, elevation of labrum.
Nothing is again not audible.
Again, I don't know, but he.
Hello.
Yeah, sir, you're not audible in between. Now
Yeah.
you're audible again.
Okay, so I don't
The
know
case,
what's happening.
the case follow-up that you were showing.
Yeah. So now that's the follow-up, and you can see the free bone block is nicely united, and the normal anatomy is uh, achieved again, and you can see buttons on either side, and that's the clinical picture showing full range of movement, and that's the scar which is showing the scapular spine graft harvest site. This is another patient, similar result, a nice solid bony union and restoring of full movement and stability of the joint. So if we look at the comparison between free bone graft and Lethargate, I think there is no much difference in clinical and radiological outcome. Rather, there was better internal rotation in ICBG group because there was no split in the subscap. So by and large, this is meta-analysis, no statistical difference. So I think you can choose whether you want to do Lethargate or you want to do a free bone graft. The results are same. Even graft osteolysis is also almost same and comparable with both techniques. And again, there is some debate about whether to use screw or a cortical button. But I think both fixation, they almost they do same. So again, coming to my summary, it is not important to just learn the technique and do it correctly. It is very important to do correct procedure for correct indication. Thank you.
Thank you, Dr. Shirish. It was an excellent insight about the Bony procedure that you can do for the instabilities around the shoulder joint. I would like to thank the panel. Sir, do you have any questions? Dr. Kamat, any questions for Dr. Pathak? Anything discussion?
So if Shirish and Vivek are both online, can yeah. Okay, so if we have to just kind of give a concise overview, Vivek, from an investigation perspective for let's say a younger colleagues, if a patient with instability does come to the OPD, a recurrent dislocator of a shoulder, a typical age group, a 22-year-old boy has had 3 to 4 episodes of dislocation. What is your investigation of choice other than a plain X-ray? Do you always do an MRI and a CT, one with the first dislocation and in a recurrent scenario? And do you do only MRI or do you do only CT? So Vivek will take your opinion first, and then we'll get Shirish to put in his thoughts.
So Nilesh, I will almost always, if it has been traumatic or relatively traumatic, some kind of overhead continuous activity has been going on for years together, some trauma, I'll always start with CT. Of course, then it becomes very difficult to do MRI in most of the setup unless and until you have a tie-up with radiologist where he gives a MRI plus CT to you. I do the MRI only when I find absolutely no CT finding. It's like, your patient has been recurrently dislocating, but you don't find a bone loss on either side. Then I am amazed that there is something else. Then I need definitely an MRI. But almost always I have gone ahead with the CT and I have never regretted that why I did not ask for MRI.
And
So
Shirish,
for me, my investigation of choice is always CT in a recurrent dislocator. Now, of course, I'm talking again about the so-called traumatic or a relatively less trauma.
Yes, we are talking about a traumatic scenario.
Yes,
Shirish,
yes.
how about you?
Yeah, so Nilesh, I would start with MRI scan, 3 Tesla, which gives me fair idea whether I'm dealing with only soft tissue repair or I'm going into the area of suspected significant glenoid bone loss. If I have slightest doubt in my mind that there is significant or subcritical bone loss, then I won't hesitate, but I would get a proper CT scan with 3D reconstruction and all calculations. But someone who has come after first dislocation or second dislocation, and if I see reasonably good bone on MRI, then I won't do CT scan.
Interesting.
But Sirish, which is that
Yeah.
section, on MRI, which gives you a fair idea that there's no bone loss? Because you see, it's like, even if you see in axial, it keeps curving. You don't know, even in CT, if you see, you need to have on-face view. Unless you
Yes.
have an on-face absolutely perfect, perpendicular on-face view, you might have seen so many times that 2D cuts, axial 2D cuts can mislead you.
Yes.
So how, and we are talking about the junior colleagues who are just growing up. With your experience, I'm sure that with 3D, I mean, with the 3D, you may be able to pick up. I cannot pick up. Many at times I have faltered, and I have told my, my juniors that I think I should have done a CT. Like, patient came with 3 dislocations, and we say, it looks okay. You go inside, you find a straight glenoid. It's like, oh God,
Yeah.
I think I should have done CT. So that's why over the years, this, it's a Pavlov pouch thing happened in the brain. So it's like first is CT followed by only.
I completely agree with that, Vivek, because this is something very difficult only on an MRI to pick it up. So, and I've racked my brains enough with radiologists at our centers in our city to discuss about this, and none of them could really give an answer. And sometimes it isn't, majority of your decisions are pre-operative decisions. You can't just change on table because the entire dynamics change. What we routinely do at our center is all our patients of recurrent instability get an MRI with local CT cuts. So that's a norm which is there. But I would agree with Vivek to a certain extent that probably if I have to make one choice, if I have those constraints and if I'm not able to get all the investigations done, then probably I would rely more on a CT rather than on an MRI, because whatever soft tissue injury is there, I'm going to deal with it anyways. It's the bone loss which is a variable which I really can't take into consideration on table, because that's going to change my decision. So that was one point to drive home that pre-operative assessment and decision making is something which is again very important. Shirish, one more question to
Yeah.
you from a lethargy perspective, right? There's been lots spoken about. There's a shift without whether it's too much of confusion for the younger colleagues, whether to do an open lethargy, whether to use screws, whether to use button, whether to do an arthroscopic bone block procedure. And I know you did show patients, or rather literature where there has been a shift. My question to you is,
Yeah.
especially in India, in a slightly peripheral setup, if you have a patient who does not have bone loss, right?
Yeah.
And if someone is not equipped to do arthroscopy, is it okay to do a lethargy, or would you still recommend that no, it is not worth it? You're burning all the bridges out here.
No, I think, see, sometimes you may have to take certain practical decision. But if you ask me, if someone has no bone loss, it doesn't make any case for doing a lethargy, because we all know that bone is going to get osteolized if it is not going to get loaded. And
True.
rather, you are heading towards a complication where bone has osteolized and you have got 2 proud screws. So I think that is a worse situation to have. So I would say basic principles, understanding and decision making doesn't change whether you are sitting in a tertiary center in the city or you are practicing in periphery. You have to do right treatment for right patient.
Absolutely. I completely agree with that. Just because that particular expertise is not there, it does not mean that you do an unindicated procedure for that pathology. Because if there is resorption, then you're left with a bigger problem of proud screws, which is going to cause an irritation to the humeral head and going to cause more destruction of articular cartilage.
Yeah.
Any other thoughts from your side, Shirish or Vivek, please?
I think everybody is very clear about the soft tissue repairs. Everybody is very fairly clear about Remplissage. I think the Bony procedures, Letage has been a gold standard for, now decades, whether you do arthro or, the scopic. But I personally feel arthro Letage can always be debated, but I think Bony block procedures, in the due course of time, as long as we perfect the fixation technique, because the debate is currently on single or double button or what, the loosening, the delayed healing, etc., is going on yet. I think in a couple of years' time, we'll perfect this technique. This is important because you have situations, as you said, now, like Sirish was showing his first case. You go inside, you realize, okay, it's about 11% bone loss, 12%, but soft tissues are bad. Now, based upon the bone loss, you have already made up your mind that I'm going to do the soft tissue. You go inside, you realize 12% bone loss, not so good soft tissue. Patients in lateral position. If you have perfected the technique of the bone block, you can go ahead. Letage means, especially letage, like people like me who want to do in beach chair, then you change the whole setup, make the patient in beach chair, and then do. So I think and it's and very rightly said, you're not going to touch anything with the subscap. Without altering the anatomy, you can still do a good job. As long as just the due course of time, another 5 years, will have the good studies, good outcomes.
Absolutely.
That what exactly happened to these bone, whether they really healed well, or should we delay the rehab protocol? I mean, that's my thought on the bone blocks.
Yeah, so I think Nilesh, we have covered almost most important points in a clinical radiological decision making and surgical technique. So I
Yeah.
think that's it.
Yeah.
I
Thank you,
think
Doctor.
we are also running short of time. We have to
Yeah.
finish
Yeah.
in time as well.
Yeah. I thank you,
Well,
Dr. Pathak, Dr. Vivek, and Dr. Nilesh for an excellent opening webinar for Arthroscopy Insights. And there's one video we want to run. Can I ask Ortho TV people to run the
Yes,
Calicut
sir. Sure.
conference video? Yeah, please.
Just 1 minute more, and then we wind up. The Arthrocon meeting, which will be held, it's the 32nd annual meeting, which will be held tomorrow, all about shoulder arthro as well as joint replacement of the shoulder.
I invite Dr. Parag
Thank you.
to just to give your concluding remarks for the today's webinar.
So I think this was an excellent. Are you able to hear me, Sunny?
Yeah, we can hear you now, sir.
Yeah, thank you
we
very
can hear.
much, Shirish, for conducting this webinar. It went really well, and I also learned a lot of new things today. Thank you very much, Dr. Spite of your busy schedule and your personal commitments being a weekend, but we really appreciate your presence, and thank you, Dr. Nilesh, again. And
Thank you.
Sunny, thank you for being there and conducting the webinar. We will be having more such webinars in the weeks and months to come, so stay tuned. And last but not the least, thank you to Ortho TV and Dr. Ashok Sham for having broadcasted this first Ortho Insights webinar. Thank you, everybody, and have a
Thank
great
you, sir.
weekend ahead.
Thank
you,
And
sir.
thank you for all
Thank
the
you, all
viewers.
faculty. Thank you.
Thank you.
Thanks all viewers. Bye-bye.
Thank you.
Yeah, ठीक है. Thank you. कौन है उधर? बंद करो. हाँ, बंद कर. चलो.